Hello everyone, hope you are doing good. Welcome again. So we'll continue our discussion. Okay. So let's start. The physician must undertake measure for primary prophylaxis of iron deficiency anemia. Which of the following categories of patient are subject to such primary prophylactic measures? So straightforward question. We don't need to think much. Okay. What happens here? Like primary prophylaxis of iron deficiency anemia, which patient we have to give iron deficiency, like iron supplement? Okay, so who needs first? Just think some conceptual thinking. Okay, who needs iron? Men or women more? Men or women? So why? I think you all know the answer. This is women. Why? Because we all know that during the menstruation period, okay, so women lost a lot of blood, and this caused the iron deficiencies among them. In India, we have about 75% women who are normally primary iron deficient. So in women, and the age is reproductive age. In reproductive age, the time is in the time of menstruation. Okay, and also like reproductive age, the woman is more vulnerable to iron deficiency, and in reproductive age, so the name here is reproductive age. So this is the time where women conceive. Okay, so in pregnancy we'll have also we can have also in some severe iron deficiency. So you all know that in women who are pregnant, we give iron supplement. Okay, we have some scheme you will read in PSM also, when you will prepare for FMG, that there is some anemia mukt bharat abhiyan. Okay, so there the government gives us iron and folic acid tablet. Okay, it is the dose are 500 by 60. Okay, so folic acid 500 and iron is 60. So this dose is given to women in the reproductive age group or in pregnancy. Okay, mainly in pregnancy. So we give iron deficiency iron supplement to pregnant women. Okay, in patient after 60, this is not indicated like we need to give iron deficiency iron supplement. All children we don't give. Patient after operation we don't give. Worker of industrial enterprise, these are not related to any iron deficiency. So most vulnerable is women in the reproductive age, which is pregnant. Okay. Then next question, a patient with unstable angina pectoris was given the following complex treatment: anticoagulants, nitrates, alpha blockers. However, on the third day of treatment, the pain still remains. Which is vegetation should be which sorry investigation this will be which investigation should be carried out to establish the diagnosis? So there is they have put the diagnosis here. It is angina pectoris. Okay, angina pectoris, and so you need to know something about this. Okay, angina pectoris, and then what happened, they have given anticoagulants, nitrates, beta blockers. These are the medication we prescribe in angina. However, on third day of treatment, the pain still remains. Which investigation should be carried out? So before investigation, we need to know the diagnosis. Okay, so here they have given it unstable angina pectoris. Okay, they have given it unstable angina pectoris. So what is a unstable angina? So first we need to know about what is angina. What is angina pectoris? So angina pectoris is, like, generally we call it as chest discomfort or chest pain. So we have three types of angina. First one is stable angina. Second one is unstable angina. If you have stable, you have unstable too. And third one is fringe metal. sorry, third one is prince metal. So what happened? Like in stable angina, we have this coronary artery. Okay. First of all, before that we need to know why angina occurs or why this chest discomfort or pain occurs. What happened? This is caused by the deficiency of oxygen supply to the myocardium. Okay, so we have a deficiency of oxygen in our myocardium, and why this happens? This happens because low blood flow to a particular area of myocardium. Okay, so why this low blood flow happens? Low blood flow, as you all know, the low blood flow or this is mainly caused by, you can say, atherosclerotic plaque. Okay, so we have a plaque in our coronary arteries. So this is our beautiful coronary artery, but you have plaque here. You have a plaque here. So what happened? The blood can't pass through how it should be. So there is obstruction here. Okay, but we all have some plaques in our arteries, but it does don't like it don't show any symptom. If you have like a severe plaque obstruction like 70%, 80%, 85%, then you will see you can may have the symptoms. Okay, so this is stable. So if the plaque is stable, if the plaque is not growing, okay, or it is a sclerotic plaque, so we call it a stable angina. What happened here? Here, you can detect yourself, mm, you will get you will you the patient will complain that if they walk for 1 kilometer or 15 minutes they are walking, then they have pain in chest. Okay, or they can't climb the stairs to second floor or third floor, these types of. So the symptoms are exertion specific, you work for 15 minutes or 30 minutes or 1 hour, after that you will having the pain. But what happened in unstable angina, the plaque is totally unstable. Okay, and what happened here, you cannot predict the pain. Okay, so you can have pain while exertion, you can have pain while resting too. Okay, and in Prince metal, what happened in Prince metal? There is no plague actually. Actually, it can be sclerotic that in that portion, but the main mechanism here is neurogenic spasm. The artery get narrowed through spasm. Okay. So this is important because in this angina we don't give beta blockers. So beta blockers are contraindicated here. Okay. And in stable angina we have staging also, you need to know. So we can discuss it later, or if we get any question we will discuss it there. Okay, and in rating this we need to discuss some more things like um our myocardium. Okay, so if they are oxygen deprived, it can survive up to 20 minutes generally in average. So what happened after 20 minutes? After 20 minutes the cells start to die. So if the cells start to die, we call it infarct. So what is an infarction? Infarction is cell death after ischemia. This is infarction. So how we'll call it here? So the death of myocardium cells after ischemia. This is myocardial infarction. So this is myocardial infarction, and we call it MI. Okay, you know it all. MI, or you can say it heart attack. Okay, so myocardial infarction. So in myocardial infarction also we have two types. This is first, there is non-STEMI and we have STEMI. So how to differentiate? It's in the name. So non-STEMI means not ST elevated MI. In STEMI it is ST elevated MI. So in ECG you will see like this. So this is our beautiful P wave, then Q, R and S, and this, sorry, my bad. So this is the baseline we are talking about. So this should be our baseline, right? This dot is our baseline. So what happened in ST elevation? The baseline is elevated. So we'll get something like this. Okay. So this is the ST. This our ST segment is elevated air. This elevated air. So it is ST. And in STMI what happened? You will have the baseline, and the ECG will look something like this. This and this, and the baseline is decreased here. Okay, so this is ST depression. So in non-STEMI we will have ST depression, and but if you want to know why this happened, this is I don't think in Krok you need it. Okay, we'll discuss this later. Actually, but like simply speaking, that this NSTMI it is what it is, subendocardial. Okay, and this is transmural. Just know these things. Okay. So like what is these things? These are the, like, if you have your heart. Okay, we have three layers. Okay, this is the in, and this is the outermost. So in the innermost we have what? We have endo. We have endocardium. Outermost is epicardium, and the thickest or middle one it is myocardium. Myocardium. So here they are saying that it is unstable angina. So you can see that we have talked about it is unstable angina. The pain is not related to anything else. As we see that anticoagulants, nitrates and alpha blockers are prescribed, but the treatment plan still like pain still remains. Okay. So what we do? What we can do clinically? So clinically, the first thing in your mind should be some investigation. What investigation we can do? We can do some ECG, right? And then we need to know about the site of the artery, which artery is involved, how much percentage involved. So we need to know coronary angiography. Okay. So ECG, coronary. Now which options are here? So we have coronarography. So we have CAG. Okay, we have echocardiogram. So echocardiogram, like, this is not a first line investigation for angina pectoris. Okay, test with those physical exercise, esophageal electrocardiography stimulator, myocardial scintigraphy. These are not the anything first line. Most important thing, physical exercise. Test those with physical exercise, or you can see TMT, treadmill test. Remember one thing, in unstable angina, anything stressful test is contraindicated. Okay, so physical exercise tests are contraindicated, stress echocardiogram are contraindicated. So we left with coronary angiography. But if they give you option of ECG, you will go that the first line will be ECG. Okay, first investigation ECG. But if they give like this, first investigation should be carried out to establish the diagnosis. This diagnostic gold standard is CAG. Okay. Next one, the 28-year-old woman applied to doctor because of limited loss of hair. In the anamnesis, she had frequent headache, indisposition, arthralgia, fever, irregular casual sexual life, drug user, uh, negative, RW is negative. What examination must be done? So this is a simple question. Here we can see that we have like she has irregular casual sexual life and drug user. What we will suspect? We will suspect first thing in our mind should come about HIV. Okay, and you can see generalized like non-specific generalized symptoms: fever, they have arthralgia, they have indisposition. Okay, like this loss of hair. So first should be HIV. So our answer is HIV here. I think I need to add something to one of our questions. I should show you a key point there. Okay, like in the second question, as we described, the answer was hemophilia A here, but there is one key point here too. That is the knee is painful, hot to touch. This is called, what is called? This is called hem arthrosis. So when you see hemarthrosis in a child, you suspect it first hemophilia A, okay, and then as I explained before, you establish your diagnosis, you confirm your diagnosis. Okay, so let's get back. 35-year-old woman was admitted to thoracic surgery department with fever up to 40 degrees centigrade, onset of pain in the side caused by deep breathing, cough with considerable quantity of purulent sputum and blood with a bad smell. What is the most likely diagnosis? What is the diagnosis here? So what we get? We get considerable quantity of purulent sputum, purulent sputum with blood and bad smell. Okay, and we have fever up to 40. Okay, so as you can see, there are options like pulmonary tuberculosis. We don't have purulent sputum with bad smell. Okay, and bronchiectasis disease. We don't have. Also, two complication of liver echinosis and actinomycosis of lungs. These don't give us like this type of bad smell and purulent sputum with fever. Okay, so this have some infection in the lung, which is a severe infection with lung. Okay, and we can suspect it here, abscess of the lungs. Like some questions here you will get, you go for the answer with your gut feeling. Okay, you cannot exclude all answers here, but you see that here you like two three things you need to see: fever, purulent sputum, and blood with bad smell. Okay, so these things all always go for like abscess of the lungs or gangrene, like some destructive things are going on in your lungs. Okay, then a 67-year old patient complains of palpitation, dizziness, noise in ears, feeling of shortage of air, objectively pale, damp skin, vesicular aspiration, respiratory rate 22 per minute, pulse 200, AP 100/70, on ECG heart rate 200, ventricular complexes are widened, deformed, location of segment ST of and of wave T discordant, the P wave is not changed, superimposed QRT, natural conformity between P and QRS is not present. So this is a very important question and a good one. Okay, so let's find what is the complaint of palpitation, dizziness, noise in ear, feeling of shortness of air. Okay, visual respiration, pulse rate, heart rate 200. Ventricular complexes are widened. Okay, natural conformity between PQ is not present, and also we have the P wave is not changed. Okay, superimposes QRT. So let's get back some. You need to get back some basic in ECG. So what happened? This is our attempt. Sorry for my drawing again. This is our SA node. This is our AV node. Okay. So whatever happens above this portion, so this portion, this is supraventricular things, and these are ventricular things. Okay. So here we can see that ventricular palpitation, dizziness, noise in ear, feeling of shortness. So we can see that these symptoms are due to the increase of heart rate. So now we need to think about where the where the heart rate is increasing. Okay, where the impulses are increasing. Is it supraventricular or is it ventricular? So how can we differentiate? So what happened? We have this P wave, then we have QRS, then we have the T wave. Okay, so this P wave, this is the atrial depolarization gives us the P wave. Then we have the QRS complex, which we get from the ventricular depolarization. Okay, this Q wave is for the septal region, this R wave. So Q wave, R wave, S wave, T wave, P wave. Okay, so this R wave is for the main myocardium and this S wave for the basal area. So if you want to discuss about this, we can have a separate lecture on this. But today I'm just generally speaking. Okay, now how to differentiate these things? So here they are saying that P is not changed. So P wave is not changed. No morphology change in P wave. So we don't have any problem in SA node. We don't have any problem in atrium. Okay, then it is superimposes QRST. So P wave is superimposes QRST. Also we can see that natural conformity between P wave. What is natural conformity? Natural conformity means QRS always will come after P. Okay, always will come after P. But here what happened? Here they are saying that it is not synchronized. So we can see some message like that, like P wave, then a P wave will come, then a QRS will come, then again a P wave will come, then again a QRS will come, then P wave, P wave, P wave, like this. Okay, so there is no synchronization between the P waves and Q waves. And so what happened? This means that these AC node, so these P waves, they are generating their own impulses, and we are getting something, some ectopic from another region. Okay, these Q waves are coming from another region. So P wave are coming from another region, and this P wave are not following the these Q waves are not following the P. So they are coming from another region. Okay, now one more thing, that is ventricular complexes are widened. So ventricular complexes means this QRS. So in normally we get what? We get a narrow QRS. So remember this, we will discuss about this later if you want. So in normal ECG we will get a QRS and narrow QRS. But when something origin from here or here or here or anywhere in ventricle, we will get a very broad QRS. Okay, very broad QRS like this. So if you see that there is P wave and this is simple beautiful QRS, you take it as what? You take it as a normal reading. But then again next impulse you get a P wave, but again a P wave and then a broad QRS. So this is not normal. Okay, this broad QRS or wide QRS, it is coming from ventricle. So what do we get? Heart rate 200. Okay, and if this heart rate is 200 and like it is making you dizzy, we call it paroxysmal. So paroxysmal, then we have ventricular complexes are widened, so the ectopic is in ventricle. POAB is not changed, so no problem in supraventricular region. So this our answer is straightforward directly. What? Paroxysmal ventricular tachycardia. If sinus, why not these things? If sinus tachycardia, what will happen in sinus tachycardia? So let's exclude these things. Okay, why not sinus tachycardia? How will you get your ECG in sinus tachycardia? In sinus tachycardia, normal heart rate is 60 to 100. What is sinus tachycardia? Tachycardia means more than 100, so it will be more than 100. But the origin is from SA node. So P wave, QRS, T, again P, again QRS, T. So these timings will be sorted down, like the timing will be less, but the P wave, then after QRS will come, then T will come, then P will come. So they will follow each other, okay, in a normal pattern. So in sinus rhythm, in sinus tachycardia, you will get something like that, normal pattern, but only the heart rate will increase. What about arterial flutter? You know about flutter, arterial flutter? What you will get in a flutter? Arterial flutter, you will get sawtooth appearance. Like you will not see the P waves. P waves will be not normal. The origin from atrium. So P waves are like this sawtooth. P waves like that. Okay. So if we, and the rate will be in atrium, rate will be more than what, more than 250, or it can reach up to 400. So the P wave will be like that. After that you will have one normal QRS, then about that P wave like that, then again a normal QRS. Okay, so these sawtooth appearance, or F, these are called F waves. So F waves or flutter waves. Okay, so these flutter waves you will get, but there is, you what you see P wave is not changed, so there is no F waves, their P waves are intact. So arterial flutter also can be our answer. So no arterial flutter, no sinus tachycardia. What is ventricular systole? Ventricular systole, as I say, like the heart rate will be normal, it will be about 60 to 100 or a little more, but the P wave will come, then a QRS will come, then T will come, then a P will come, then maybe a broad QRS will come, and T will come, and then again normal rhythm. Okay, so there may be one extra beat, one beat which is abnormal here. Okay, but what they are saying, they are saying no natural conformity between P and QRS. Okay, so extrasystole don't give you a heart rate of 200. Okay, they will not increase your heart rate to 200. And what about arterial tachycardia? Arterial tachycardia, it is same as sinus tachycardia, like that, but the P wave morphology will be changed a little bit. So P wave morphology is not changed, and uh, in arterial tachycardia we will have the conformity between P and QRS. Okay, narrow QRS will come after P. So this can be our answer. Okay, Thank you for watching our videos. See you in next video. Thank you. Bye bye.